Now, what had Gordon planned to do and what are Trevor and I going to do instead? So Gordon had been asked to kind of debate with himself about should all patients be treated with DMTs, okay? And he'd produced his slides, and we have his slides. He also was conflicted. Okay, and Gordon's first slide was going to be that really you can't think about all MS patients and really answer this question. Okay, the first thing you have to do is think about MS patients at different stages and think which of those would you treat and should they be treated. I think quite rightly, I would agree with, he breaks this down to patients with radiologically isolated syndrome, clinically isolated syndrome, relapsing remitting disease. He had benign MS. Okay, which fine, secondary and primary. Okay, so how in your head would you answer the question yourself? Should all patients in any of those categories be treated with disease? Okay, and that's what he was going to go on to do. Okay, I'm going to answer a few very quickly, okay, and pretend that there is an answer for them, because what we thought is we'll focus in on probably the most controversial ones, which is the beginning and the end, okay, on the assumption that the middle, I think we're fairly, I'm guessing most people in this room are fairly happy with. So I'm going to put CIS in the middle, okay, if only because the great and the good have got together and answered this one for us. So in the last couple, well, basically last year, or actually, no, good grief, it was 2 years ago, 2017, the Americans all got together to produce guidelines for the treatment of CIS and RMS, and the Europeans, EAN and ECTRIMS, got together to form, and they both produced massive documents telling us what everyone who had access to all the literature believed, okay? You can debate it, but essentially what we have is the European one. For the last little while, we can use that flag. Okay. What can we say? And basically what was that you should offer glutaramase to patients with CIS and an abnormal MRI with lesions suggestive of MS, okay? And that is considered to be strong advice. So rather than re-debate that again, we're going to take that if you have CIS with lesions suggestive, you really should, okay? And you should offer early treatments to patients with active RMS, including CIS patients who fulfill current diagnostic criteria. Now, as we know, most CIS patients now do fulfill diagnostic criteria for MS. So basically, I think CIS, the answer's fairly much there. In the UK, the algorithm kind of allows you to do this with a bit of activity. You sometimes be a little bit creative, okay? And we're a little bit restricted in some of the drugs we can use. But the question Gordon was asking was, should you treat, not necessarily what should you treat with. Okay, and the Americans came up with exactly the same thing. Patients should discuss the benefits, okay, and having discussed, should prescribe, okay, for patients with CIS and 2 or more brain lesions, okay, so we're kind of happy on the CIS front. RRMS, okay, again, European, basically anyone with active MS, okay? And again, we're fairly happy with that. I'm guessing in this room, most people would probably like to treat everyone with active MS, would probably like to have the full range of drugs to treat them. You'll know that the algorithm for the English people here does constrain us a little bit around the start as to what drugs we could use. If you're Scotland, Northern Ireland, or Wales, I think you have a little bit more freedom than we do in terms of reimbursement. Okay, and the Americans came up with exactly the same thing, relapsing forms of MS with recent clinical relapses. And this is quite a clever thing that I think a trick the Europeans did miss, which is if you haven't had an attack for 10 years and you pitch up, okay, you wouldn't necessarily treat that person. You might allow the fact that you have 10 years of reassurance to let you through. So we're going to kind of take those ones in the bag, okay? So what we decided was that the 2 things we might think about is what about radiologically isolated syndrome? And what about secondary progressive disease? So should we treat at the very start and should we treat at the very end? I'm going to present a couple of slides, a couple of Gordon's, a couple of mine's. I'm going to throw it open to the floor for a little bit of discussion, okay? And Trevor's going to put in his fine Welsh view as well. And then we're going to swap round for secondary progressive disease, and hopefully that will fill half an hour. That's the plan. So, should we treat RIS? What is RIS? So RIS is radiologically isolated syndrome. This is usually someone who's been scanned for another reason, a headache, cognitive impairment, by accident. Okay, in London where people have money to burn, they sometimes just go and have MRI scans, I think, just for kind of health checks. Okay, and what you're going to find, and some of those will have a scan that looks like MS. term was first used 10 years ago. It's likely there's a massive group of people here, okay? And we've had, as you may know, there's the Barkov criteria, which are the old MS criteria, which sort of needed 9 lesions, okay, if you go back to those days. The Swanton criteria are the ones with just 2 suggestive lesions. So even when you look at an RIS study, you want to look and see what criteria they're using. So how many people are out there with it? Okay, it's suggested that maybe, okay, about 1 in 1,000 people is running around with this. Okay, Sweden have interestingly done an incident study. So if you practice medicine the way they do in Sweden, and I suppose we do, okay, do you have MRI your headaches? Okay, do you MRI certain forms of trauma? The kind of people that get MRIs, how often within a year will you turn up an RIS? And in Sweden, they're turning it up roughly 1 in every 100,000 patients. Okay, so again, in my catchment area, we have about 2 million people, so we might expect to turn up about 15, 16 people with RIS a year. I think that's more than I do see, okay? I think we see maybe 2 or 3, okay? But that's kind of what the Swedish instance would be. And don't forget, this isn't a true incidence because it's not a disease. This is how often you find people with abnormal scans. What happens to these people? And a couple of studies have shown that about 1/3 of them will have a clinically isolated syndrome at 5 years, okay? Now, what you want to contrast that with is if you come with a clinically isolated syndrome, the chance of you having a second lesion or new MRI lesions by the end of 2 years is nearly 85, 90%, okay, in this kind of study. So these patients aren't quite like CIS, okay? That's a lower rate of conversion that you might expect. 2/3 of them will have new lesions, and it's not just that you can be certain they're going to develop RRMS, 10% of them will go on to develop progressive disease, and as we think about treatment, that's going to kind of affect what we do. So, do these patients look like CIS, or do they look like healthy controls, okay? And it depends a little bit in the study you look at, okay? And I haven't got all the detail here. Studies have been doing looking at cognition and quality of life in people with RIS and people with CIS. And what they've found is that quality of life and cognition in RIS, they behave a bit like a CIS population, okay? So what this has been interpreted as saying is that actually these people essentially already have pre-MS, their cognition is already falling, and their quality of life has already fallen. Interestingly, a couple of harder studies, however, looking at functional connectivity. And if you have MS or CIS, your brain works, but to work well, it has to work a little bit harder. And we can see that much more of the brain is networked in people with MS and CIS because it has to pull information in from other places. If we look at the functional connectivity in RS, however, a lot of them look like healthy controls. Okay, suggesting that if you tell someone you have RIS and you might develop MS, and then you test their cognition and ask their quality of life, and they're in a study looking at quality of life in people with pre-MS, they don't all do all that well. Okay, perhaps not a big surprise if you look at some of the harder measures. And the likely thing is, to go back to the first one, this is probably a heterogeneous group of people. There are people there with pre-MS, and there are people who don't, but we're not that good at telling the difference between them. So if we look at RIS, okay, this is one of Gordon's slides, okay, mean age, kind of around about 37, okay, following up for 4 years, the same figure, about 30% will have a clinical event, okay, but again, of the ones that have clinical events, some will have progression. There are things that tell you whether you're more likely to get MS, okay, male gender, lesions within the cervical or thoracic cord, okay, neurofilaments, okay, again we'll see in some RIS that we see increased neurofilaments, again suggesting that some of these, at least in that group, there are some people with a kind of pre-MS state, okay, that's the study I was talking about. Cognitive performance, suggesting that they are below the healthy age population, but again, you might want to say that these are a group of people who have been told that they have a potential diagnosis. So we're going to talk about a little bit, and then throw your own views as well about where they should treat these people. It's interesting to think who these RIS are, though, and I put this slide because I think this is an important one for me. Who is most likely to have a scan looking for MS? Okay, and the answer is someone who is a relative with MS. Okay, and this is a slightly scary side. Again, if we look at the Swanton criteria, the two, and we look at people with a healthy relatives of patients with MS, of 60 people they looked for, 7 of them, okay, had 2 funny lesions on the scan that you could potentially say would do for MS, and much higher in non-familial healthy controls. Okay, so if you're going to start treating RIS, okay, and you're going to start looking for it, okay, are you in the situation that 1 in 10 of your relatives with people with MS, you're going to go in, scan, and if they have 2 dots, are you ready to treat them? Okay, so discussion. Trevor! Okay. What are you doing in Wales? Do you treat RAS? Do you go looking for it?
You don't have much choice in terms of going looking for it because it finds you most of the time, I find, and you probably know this yourself. You made a very good point that people have MRIs for a reason. They're not just, the vast majority anyway, are just not off the street patients who are completely asymptomatic. So maybe they've had it for a odd sounding headache, because I don't do MRI scans for people who've got classical migraine within a certain age range or who have tension type headache. We do MRIs for people who've had a first seizure, okay? And there's an increased risk of seizures in MS, for instance. So are they truly RAS, or is that, is there epilepsy a sign of brain disease which is caused by inflammatory brain lesions? Is that truly RAS, or is it actually just an unusual first symptom of MS? So what do we do in Wales? Like yourself, I'd say the numbers we see are very few, probably definitely single figures, probably less than 5 a year across the department. And almost certainly they're not treated. Occasionally we'll see a patient with an RAS who we will then repeat their imaging to try and help them understand the problem, and they look like they've got an active scan even though they're completely asymptomatic, and I think that puts you in a difficult position. And that's in Wales we don't have blue tech, yay. We have ourselves and a rather lax management structure, he said, within these 4 walls, and we're not audited that much. And
for my taxes going.
Yeah, our clinical board. Well, the Welsh government can raise their own taxes, actually. Which is great. Yeah, we as long as the DMT multidisciplinary team meeting, there is documentation there has been an appropriate discussion between at least 2 consultants and other relevant MS specialists in the team, and the radiology has been discussed, and the criteria have been checked, and then some clinical opinion has gone in. If we feel a patient should be treated, we can treat them. I don't think, he looked over there, I can remember treating anybody without symptoms who's just got an MRI that looks like MS.
Thomas?
Could we? Yes, I think we could.
Yeah. Thomas?
You rapidly went through the slide with the oligoclonal bands. And
yeah.
Quite high
hazard
ratio.
It is.
Like 40 or something. So
yeah, I'm going to show it again, actually.
Be heavily weighed into this.
Yeah. So, and have you treated an RAS?
No, the only RAS I had was negative.
Was negative, yeah.
I just made a new MRI 1 year later.
So would you agree with us that it's maybe not as common as some of those figures might suggest? Although I hate to come out, the figures are from Sweden.
I have no idea.
Yeah. So anyone treating RAS out there? Okay. Okay, so look, I'll kind of try to wrap this section up a little bit. So I think, again, to my mind, with RAS, it kind of is the new frontier of treating now. It sounds a little bit like where the CIS debate was around. Mm-hmm. So for not treating, it's the fact that 7 out of 10 will not have relapses in 5 years. Okay, there's a little hint in a study I haven't shown, which is that there may be a higher repair rate in this group. Okay, so there may be some people who have a pre-MS state who cure themselves. Okay, and that might be kind of a little bit, if we look at the very high incidence of MS-like lesions in relatives of MS who don't go on to develop it, there may be people with some susceptibility genes but who do remyelinate, who do better, and there may be a group here, and that's a little bit speculative. The other one in terms of treating is, as I say, 10% will be progressive MS. So you may think, you've got an active scan, I'm going to stick you on natalizumab, okay, because you've got such an active scan, and you'd actually be treating them with a drug that wouldn't work for the phenotype of MS they were going on to develop. Okay, however, as Thomas suggests, there are strong predictors coming through now that we probably can recognize people if you're GAD positive, if you've thalamic atrophy, if you're young and male, if you've brainstem, if you've oligoclonal bands. The more of those you have, the more likely you are. So my suspicion is that in time we will not be treating quiet RIS, but it may be that we'll spot people who are so likely to develop MS that you could maybe think about treating them. And as I said before, when you don't know what to do, you do a randomized trial, and I've already showed you that there are 2 randomized trials going. So the answer, this will not remain unknown forever. The answer is out there, okay? Again, if you want to be strict, completely strict, okay, the current advice is, again, the great and the good got together and they said, if you have a scan and you've gadolinium enhancement and you have bands and that scan is changing, at the minute, as of 2018, you still don't call it MS, and it's still recommended not to treat. So that's the European guidelines on the management of MS as they stand at the minute. Okay, this is kind of, part of another talk. I would have taken the animations off if I'd known this would be a quick one. Okay, this is my kind of heat map, okay, of my enthusiasm to treat. Okay, so I think if we have RIS with no evidence of activity, okay, I just don't, you know, a couple of lesions and nothing's happening. RIS with activity, okay, it's challenging. It might be a little bit more enthusiastic, all the way up to treating people with RRMS. Any questions on the RIS section? So one of the reasons for actually enthusiasm, and I've forgotten the whole reason for putting this section in, was I want to discuss what I do with them. Okay, so yeah, I do tend to follow them up. Okay, one, because I think a bit like everything else, if I tell you come back when you have a problem, it requires you proactively to come back, okay? Whereas if I see you regularly and say, have you had a problem, I'm maybe more going to likely to get that attack. And I want to get these people early for a diagnosis, and I refer them to the MS nurses. Okay, I think 2 reasons. One is they're going to go away and think I have MS, and they're going to see people in wheelchairs, and they need MS put in context. The disease they might have, they need explained to them, even though they don't have it. And again, I'll be telling them the one thing that will make me interested in you is if you have symptoms suggestive of MS. And they say, what are those? And you hand them an encyclopedia, and I say, I have a lovely group of people who, if you tell them your symptoms, they will tell you whether you might have it or not. So I must admit, I do get the MSs involved with all CIS and with RIS when we have it, because I think you have a real role in helping those people come to terms with what the disease might be and reassure them it's not that bad, and help them to sort their symptoms out when they come. Good.
Great.
Trevor.
So what you have seen there, ladies and gentlemen, is the very definition of winging it. So that's what we're doing. I think Martin made a great point about that subgroup of patients whose biology, whose immune system is special. And I wish we knew who they were. And you were talking about the RIS, CIS group of patients, but we've all got, I'm sure we've all got patients with relapsing MS who do have, who've definitely got MS and definitely have relapses, but they have very mild sensory episodes. Yet they have a horrible looking scan with 10 new GAD lesions. And yet they're so well. There must be something different about them as well. And if we could find what their biology was, that very small group, maybe 1 in 20, who seem to do really well on mild treatments, you wouldn't dream of not treating them, but I just wonder if they really need the high efficacy treatments. So anyway, there's a special group of patients. Well, they're all special, of course, but some of these people have different biology. There's no doubts about it. Right, next debating point. Should DMTs be continued in secondary progressive MS, and if so, for how long? We chose RIS because it's very interesting, and the jury is out and the decision's yet to be made. This is very much the same thing. We've all got these patients. It's not 1 or 2 per year like it is with RIS. So these are, much of this is Gordon's slides and information. These are the current DMT stopping criteria from NHS England. 1 and 2 are for your standard RRMS patients. I don't think there's any real debate on those right now. So number 1, no reduction in the frequency or severity of relapses. Well, they need a different DMT, don't they? You're not just going to stop them and leave them because their disease is very active. Intolerable side effects, absolutely. So the answer to the main prime question in this section, should all patients with MS be treated? No, because we are actually talking about individual patient decisions here. Let's not forget we're We're not just treating a disease, we're treating people. And they will have their own views as well. And some people are extremely risk averse. So that's an aside, but let's look at secondary progressive MS. So the criteria you see here, development of the inability to walk, EDSS-7, persisting for more than 6 months due to MS. Confirmed secondary progressive disease, this is what Martin was talking about, with an observable increase in disability for more than a 12-month period in the absence of relapse activity. Well, I hate to say this to you, but I think that just shows the drug is working and you've turned off the inflammatory disease in somebody who also has the slow degeneration, which, as we've heard half a dozen times in the last 24 hours, goes on from the beginning. And they specify an EDSS of 6 or greater. Well, I don't know what it's like in your patches, but in South Wales, most patients who've been told they've got MS go by a stick. You know, many of them just get it for balance, for a bit of confidence. Do they really have an EDSS of 6 if you take the stick away and make them go down the long corridor? I don't know, because we don't do that. Well, we do sometimes, but not very often. And those criteria will lead to the stopping of, or should lead to the stopping of all DMTs. Do you all do that? Quick raise of hands. No, nobody does it. So, confirmed secondary progressive disease with an increase in disability in the absence of relapse activity. These are people on treatment, don't forget. So what the questions we need to ask ourselves: what is the frequency of relapses in this group of patients? What is the contribution of relapses to their disability? We use a phrase relapsing with sequelae, so not everybody who has a relapse goes back to normal. If you don't go back to normal, then you have had that stepwise increase in your disability, your symptoms, your EDSS, for many of them, though not all. And what about the what if question? What if I stop this drug, doctor? What if I stop this drug? Actually, for some patients, that can be disastrous, and we've heard that many times as well, the rebound after stopping Tysabri and fingolimod in particular. So, looking at those questions, what is the frequency of relapses in SPMS? Yes, of course, the relapse frequency decreases in secondary progressive MS, but that's partly a disease duration effect. We know from population studies that the longer you have MS, the lower your relapse rate. And if you look historically at the pivotal relapsing remitting MS studies in the 80s now, you know, they had relapse rates of 1.5 to 2, which was average back then, we would now consider highly active disease. And as the years went by, those studies were recruiting patients with relapse rates of 1.2, 0.8, 0.6, and small differences. So relapse rates change the longer you have disease anyway. So after progression starts, only 1/3 of patients continue to get relapses. And in about 3% of patients with clinical primary progressive MS, they do get relapses. So it's the vast minority in those cases. It's a decent minority in SPMS. And most of them occurred, nearly all, 9 out of 10, within 5 years after progressive disease onset. But when is that progressive disease onset? Is it when the patient says, well, you know, for the last year my walking has kind of got a bit slower? Or is it, well, my hand's been permanently numb, might be getting a bit clumsy over the last 2 years or so? Or is it, well, you've had MS for the last 10 years, you've been progressing for 10 years, because we know that's what happens biologically. Age has to come into it, I think, because again, the population studies of untreated patients, over the age of about 50, your relapse rate is 0.1, 0.2 per year, okay? So the older you are at diagnosis, the less likely you are to have any relapses at all. So there's an argument even for RRMS patients who are in the older age group, there's not that many of them, maybe they shouldn't be treated. So don't forget age. So if you've had MS for 20 years and you're over the age of 50, you are very unlikely to be having relapses in the natural state. Untreated, never mind on treatment. So should we be continuing disease-modifying therapies in that group? I would be sceptical about that. What about the contribution of relapses on disability accumulation? Some studies have shown no influence of relapses on progression, but patients get confused as to what you mean by progression. Actually, so do I when I read papers, because SPD, sustained progression of disability, can be caused by a relapse giving you worse walking, and then you stay static for 5 years. That is, under the trial definition, sustained progression of disability. That's not the same as secondary progression, and we've got to be careful with our nomenclature. So some of these studies are showing that relapses during secondary progressive MS have a non-significant impact on the time taken to reaching EDS6. Ergo, maybe you shouldn't be continuing to treat them. What about discontinuing, the flip side of the coin? This is we've talked a bit about the pros of stopping treatment, and don't forget you all have a duty to spend NHS money wisely. And although we loathe NICE sometimes, their statistics are pretty good. And you've got to look at the number of hips, the number of nurses, and the number of hospital beds that you could be spending money on. Controversial, but true. That's what our politicians have to do, I'm afraid, and we have a duty to look at that as well. Should we be stopping immunomodulatory treatments at all? Well, there was this study from a couple of years ago, 100 SPMS patients on first-line low-efficacy treatments, the injectables. 33% had a relapse or new lesions. I don't know what the divide there was within 3 years. 5% only 5 patients had relapses that increased their EDSS, as opposed to their EDSS gradually getting worse anyway. And the main predictors were, as you might expect, enhancing lesions in the first 3 years of discontinuation, and indeed lower disability. Because the lower the disability, the more likely you are still to have relapses, I think. That, again, is just a time thing. So it's complicated, and Gordon was going to show you a case. So somebody who was on the Ascend trial, they stopped Tysabri, and then they had a pretty bad brainstem relapse. You don't want that to happen. It's much more likely to happen with Tysabri. And we're looking at patients in Cardiff now who are on their sort of dose 120, month 120, month 150. They've been on this 10, 12, perhaps longer years, and yes, a proportion of them are getting worse, and it is really hard to know what to do with them. I won't go through that because it's not my slide and I don't understand it. Okay, so back to age, middle-aged patients, first-line drugs versus natalizumab, looking at discontinuation, secondary progressive patients who stop therapy with at least 5 relapse-free years, the American criteria. On discontinuation of those, a third relapsed within the next 5 years. Again, if you look at the overall number of relapses that those drugs might be saving if you continued, that might tell you that it's a very low number for a very high price. Again, that's a population argument, hard with an individual patient in front of you. With Tysabri, as opposed to what we might loosely call first-line DMTs, I guess that means injectables rather than the orals that we've seen in the last few years, a much higher proportion developed more severe relapses. And that's a pattern I think we would all recognise. And that makes that group, it's a much harder decision, I have to say. Martin, your views?
You get again first.
With regard to natalizumab, we have seen the same, that there is a rebound activity, and also to some extent with Gilenya. What we do is to give the patients a couple of courses of rituximab.
Okay.
And then it all works out. So stopping...
Did everyone hear that okay? Yep.
I tried to stop a patient on Tysabri, 68 years of age. He became worse, and he called me Dr. Mengele or something. And since that patient, and we have as routine to treat them for some time with rituximab, and then it's all smooth and works out.
Yeah. So again, that was kind of the comments we were chatting before about what we think about this. I think first off is to, and I'm a keen treater, and I hate the NHS England stopping criteria. I'll kind of start with that one. But I'm happy to say I've stopped a whole stack of people safely off interferons, okay? And we've nurtured it through, you know, so it can be done. How did we do it in those days? You started to tell people, within the next couple of years, I'm going to want to start to stage your drug, okay? And I told them the next day, are you getting side effects? Okay, and I think I got all those patients to come in and say, I think I'm ready to stop my drug, okay? So I think you can seed it, you can get it going, you can make it a mutual decision, you can make it in the patient's interest. I have a strong feeling, despite my scientific background, that I think interferons rejected patients when the time was right. And I think if you looked at patients in secondary progressive disease, the number that spasticity got worse, that had their good and bad rebiff days, and they came in and said to you, you know, I'm ready to stop. So I think we had this sussed with the last group of drugs, and I think we did get people safely off round about EDSS 6.5, lit 6.57. I started to talk to them and got them off. So there's been nothing new about that. I'm happy that that stage of illness does not need treated and cannot be treated. It's very different with the modern drugs, exactly as you say. Stopping Tysabri is dangerous whatever age you are, and fingolimod we've seen nasty rebound as well. So we do need strategies. Interestingly, I'm pleased to hear you do that, because that was exactly what I was thinking, which is we need a drug which is going to be like, I don't know what the Swedish equivalent is, a kind of shot of Harpic round the rim before you go, okay? Be it, you know, an ocrelizumab or rituximab or a couple of years of cladribine, one of the drugs that is active but with a long tail, okay, that you can go in hard and that drug will gradually wear itself off as people go through, which is very different from the cliff edge of stopping a lymphocyte trafficking drug. So I think we do need to do it. I think, as Trevor has pointed out, as Gordon's slides are, there are large people who are never going to relapse, okay? And we've,
we knew who they were.
Much like the RIS, CIS, we've seen what those figures are. We don't know how to spot who's going to relapse off drug with these, but there are 2 studies going on to do it, okay? Everything in your world has to say, let's see the result of those studies, let's see the predictors of who stays off, and then make a national policy, not make a national policy based on a 1-year criteria. And it's even harder, I think it's a little bit wicked, this kind of 7-1. I have a lot of young people, not a lot, but 10 young people in wheelchairs, EDSS 7 following 2 relapses. Perfect cognition, perfect upper limb function, no lesions in their brain. Are you going to stop that person's treatment because they're EDSS 7? So I think blanket rules, all patients, everyone over 7 do need to go. But I think the keen treaters like me need to work with the economists more to work out how we can stop people safely. But I think it's premature to have criteria. But I think it should, and I'm happy that it's now part of every annual discussion with our patients about should we stop, okay? And sometimes they're very keen to stop when it's you that's keeping them on it, okay? So I think we do need to think stage 1 is to get that into the discussion. Stage 2 is to look at the big studies showing who can be stopped safely. I think we will get there, but I think a blanket rule to stop all drugs in all patients at a certain point it will be disastrous.
Who discusses stopping criteria when they start treatment? Yeah.
Can I say that if you're NHS England, you actually have to sign a form saying that you've done that?
Oh, right, okay. So all of you, great. I mean, personally, I think it's unfair to actually discuss stopping criteria, but telling them this isn't a lifelong drug. There will come a stage where, this will no longer be working. And sometimes that's hard to identify. I'm sure patients must understand that.
Yeah. I think a little bit like we were talking this morning about, should it come as a surprise to a patient to secondary progressive disease? And to my mind, I'd feel a little bit failed if a patient, I've got secondary progressive, where did that come from? These are discussions you should be having all the way through. RIS, you might have CIS, what's that going to mean? You might have you're going to develop clinical progression, the drug's going to stop. These are things, there's no surprise here. We should be getting patients through not this decision, but this decision and the next one, which is your job. Okay, shall we wrap up? Okay, that was Gordon's one, so that's what we did instead, and that's us. Thank you.